Welcome back to my channel. Today we are going to discuss about the green top guidelines which are regarding the obstetric cholestasis. Let's start with the vignette and it says Grafter 2 para 1 at 34 weeks of gestation develops marked pruritus especially on her palms and soles and mildly elevated LFTs which are liver function tests and elevated bile acid. What are the diagnostic possibilities and what conditions likely to reoccur? It is a typical case of obstetric cholestasis. Hints are pruritus, which is especially on hands and soles, mildly elevated liver function test, elevated bile acids. So let's discuss obstetric cholestasis. Starting, what is obstetric cholestasis? Everything which we are going to discuss today is according to green top guidelines which are from RCOG. So starting with the definition, what is the definition? It is a multifactorial condition of pregnancy which is characterized by pruritus in the absence of skin rash and with abnormal liver function tests, neither of which has an alternative cause and both resolve after birth. This is the definition given at the top of the guidelines. And what is the pathophysiology? It occurs most commonly in third trimester around 30 and 32 weeks according to green top guidelines, and it causes a buildup of bile acids in the body. What is the incidence? In UK, 0.7% and more in Indo-Pak Asian origin, and where it is 1.2 to 1.5%. Moving towards the causes and risk factors. Exact cause is not known yet. Whereas hormones, genetic factors and environmental factors, they play a major role. And estrogen hormone, they may affect the liver function test. Ethnic groups are very important, such that it is more common in the women from South Africa, India, Pakistan and Scandinavia. And what are the signs and symptoms? The most important sign or symptom is pruritus, which is without rash. Typically, it worsens at night. It involves the palms and soles. Some patients, they might present with dark urine, pale stools, steatorrhea, malaise and jaundice. And how we are going to investigate and diagnose it? For the diagnosis, it is the diagnosis of exclusion. Complete history and examination is very important. Take personal family history, history of multiple gestation, history of hepatitis C, gallstones, it is very important. On skin examination, there is a dermatographic artifacta which is seen in obstetric cholestasis. It is a skin trauma with the intense pruritus. It differs from eczema and other skin lesions. And other differentials, they include the preeclampsia, acute fatty liver with abnormal liver function tests, extrahepatic obstruction with gallstones, acute or chronic viral hepatitis, primary biliary cirrhosis, and chronic active hepatitis. Investigations, they include the unexplained abnormalities in transaminases, ALT, AST, gamma-glutamyl transferases. Bile salts, they are considered to support the diagnosis. There will be raised ALT, raised AST, there will be raised ALP, but ALP is mostly due to placenta, hence it is not considered. Raised bile acid, it can be present, it cannot be present, but it is important in the patients with the typical pruritus but normal liver function test. In these patients, you will repeat liver function test after 1 to 2 weeks. Liver ultrasound is very important. Serology for viruses A, B, C, Epstein-Barr virus and cytomegalovirus is important. Liver autoantibodies, antimitochondrial antibodies, they are done to exclude the primary biliary cirrhosis. Anti-smooth and muscle antibodies, they are done to exclude the chronic active hepatitis. Now move towards how will you manage this patient. There is no cure unless baby to be born. You need to counsel the patient for the risk factors, for the complications to the baby and mother. You can counsel patient to take cool baths and wear loose clothes and to control the symptoms with the antihistamines or the emollients. Now, second is the cholestyramine drug. It is poorly tolerated bile acid, which is a chelating agent and it may improve symptoms. Vitamin K. Women, they should be advised that when growth hormone time is prolonged, the use of water-soluble vitamin K in the dose of 5 to 10 milligram orally, it is indicated. And now to the ursodeoxycholic acid. It decreases the bile acid levels and hence rapidly improves the symptoms, and it also helps to improve the liver function test. As adenosylmethionine, there are insufficient evidence to demonstrate whether it is effective or not, hence it is not recommended. Dexamethasone should not be the first line treatment. And now to the management for the delivery. A detailed discussion, it should be taken place with the women regarding the induction of labor after 37 weeks of gestation. Inform the patient regarding the perinatal morbidity from earlier interventions. Women, they should be informed that the case of intervention is stronger in those with severe biochemical abnormalities. They should inform with the increased risk of maternal morbidity from intervention at 37 weeks. In Green Top guidelines, it is 37 weeks. Women, they should inform the inability to predict the stillbirth if pregnancy continues. There is less evidence. However, induction is done at 37 to 38 weeks when the bile acids are more than 40 micromole per liter. It is written in the EBM. Now, how will you monitor the patient? Monitor LFTs and clotting times regularly. Once a patient is diagnosed, do liver function test weekly till delivery. Monitoring of blood pressures and urine routine examinations, it helps to exclude other causes of pruritus. What are the complications? The maternal complication, it includes a maternal morbidity. It increases with intense pruritus and sleep deprivation. During delivery, there is increased risk of postpartum hemorrhage because of the deficiency of vitamin K, which is due to steatorrhea malabsorption. And it also increases the chances of cesarean section if you do the early intervention. The fetal complications includes spontaneous preterm birth, meconium stained liquor, fetal distress, early births. However, intrauterine death, it is rare, but it does not correlate with the symptoms and transaminases. How will you monitor this patient? We have done with the monitoring. Now move towards a follow-up and the postpartum period. You need to defer the test at least for 10 days as it or LFTs, they increases in the first 10 days of the purpurium. It is suggested that liver function tests, they should be done at 6 weeks and appointment they must made at 8 weeks of the postpartum. After delivery, LFTs, they turns to normal levels. Patient, they should be counseled regarding the cyclical itching, which is during the menstruation, or with the estrogen containing oral contraceptive pills. There is an increased incidence of obstetric cholestasis in the family members. What are the chances of the reoccurrence? Green Top guideline says that there are the 45 to 90% chances in the subsequent pregnancy. So let's see our question again. It was a patient with 34 weeks of gestation who has pruritus, which is more on palms and soles. There were deranged LFTs and bile acids. So our diagnosis we made is obstetric cholestasis, and what condition? It is likely to reoccur in a subsequent pregnancy because it is estrogen related hormone. Whenever there is estrogen, it will cause reoccurrence. It also have seen that it is with the use of estrogen oral contraceptive pills and in mid cyclical menstruations. So that's all for today. Hope you have understand all of the obstetric cholestasis. Let me know which topics you want me to explain. Thank you. Bye bye till next video.